Hi guys, so still on the Rcgp Sca preparation. Let's go through this vital information which is readily and freely available on the Rcgp website, and that is the documentation or the documents on feedback statements for the Sca. So essentially, these feedback statements of the Sca highlight the things that can make a candidate perform poorly or fail the exam. So it's good to know the things that you should do as well as knowing the things that you should not do. So let's go through these feedback statements. The provision of examination feedback is critically important for ongoing examination preparation, and these will be provided for all trainees in the Sca. The feedback statements below relates to the standard documents for the Sca. These maps to the capabilities used in the workplace-based assessment. Your ability and familiarity with the capabilities for workplace-based assessment should support your performance in the Sca. Feedback will be case sensitive, will be case specific, and linked to the marking domains. The feedback statements are not performance indicators and play no part in the marking process for the examination. The examiner will have marked the case before selecting the relevant feedback statements. They are not designed to provide a justification of the mark and may be offered. I find this quite ironical, or because I think actually the feedbacks in a way would be a justification for the mark. For instance, if an examiner scores a candidate poorly in the data gathering and diagnosis domain, then it's just commonsensical that the feedback that the examiner is going to put there will reflect why the candidate was scored poorly in that particular domain. Any domain which is failed by the examiner will receive feedback. Any selected statement should guide your future preparation, particularly if these appear more than once. Feedback will be released with your results. So it's important to remember that feedback highlights general areas for improvement. There will have been many areas that were done well, which cannot be documented in the allocated marking time for the examiners. In addition to the feedback statements, educational notes have been written on all feedback statements. These link to the capabilities used in the workplace-based assessment, and it will be recommended to view the competent word pictures. So a Word document that just shows exactly what's the capabilities that we have on our 14 fish portfolio, exactly the same thing, the word descriptors. Within that capability on the Rcgp website, the educator notes define the feedback statement. They also make suggestions using specific examples to help support your understanding and learning on how you might demonstrate this area in the future. We encourage you to share this feedback with your supervisor. So the first one, data gathering and diagnosis. Let's have a look. Standard for marking domain 1, passing level. The candidate systematically gathers and organizes relevant and targeted information to address the needs of the patient and their problems. The candidate adopts a structured and informed approach to problem solving, generating, when they say informed approach simply means using the information you've gathered from the patient or actor, and also using information that you've gathered from your experience as a doctor, from your experience in your 3 years of training from your knowledge and experience as a medical student years past. So everything you've known, informed approach to problem solving, generating an appropriate differential diagnosis, or relying on first principles where the presentation is undifferentiated, uncertain, or complex. Essentially, being organized, managing your time well, collecting relevant information in your data gathering, and being systematic, having a structure. Okay. Feedback statements for domain 1. So what are the things that a candidate would do wrongly in domain 1, or could do wrongly or incompletely or incorrectly in domain 1? Data gathering was insufficient to enable safe assessment of the condition. For instance, if you should have checked for the presence or absence of red flag symptoms and you didn't do that, if you should have considered a few differentials and you didn't do that, you just jumped in straight on to make a diagnosis without really exploring if other possible symptoms or associated symptoms are present or absent. For instance, a patient who has a cough for 3 weeks, you've not asked about hemoptysis, coughing up blood, weight loss, if you've not checked if this patient is a smoker, if there's a family history of any any malignancy, for instance, lung cancer, you haven't asked these questions. Or a patient who's been coughing for 3 months and you haven't checked if the patient has had any international travel or any contact with someone who's been coughing as well, to be thinking of possibility of things like tuberculosis. You need to think broadly. So you've not checked differential diagnosis, you've not rolled out red flags where needed, you might be scored poorly. Existing information about the case was insufficiently utilized. So you're giving some information, patient's BMI is there, patient's blood pressure is there, you're giving certain blood results, so certain information from previous consultations, which are important, and you haven't utilized them, you haven't mentioned them, you haven't acknowledged that this patient was seen by your colleague a week ago and the blood pressure was raised, for instance. Relevant psychological or social information insufficiently recognized or responded to. A patient with chronic fatigue syndrome or fibromyalgia kind of symptom or whatever, chronic pain syndrome, and you haven't really checked about their mood, are they feeling low, exploring for depression, anxiety, and things like that. Data gathering was unsystematic and or disorganized. Even though in the Rcgp, in the SCA preparation course, data gathering was unsystematic and or disorganized. So even though during the Rcgp SCA courses we were told at several points in time that structure would not be marked, obviously if you look at these feedback statements, having a structure, being systematic is a huge plus, and it just makes your data gathering and management much more reasonable. Ineffective approach or prioritization in data gathering when presented with multiple or complex problems. So when a patient, for instance, comes and says, "Doctor, actually I want to discuss 4 things," how do you approach that? If you're not able to approach that by finding out, okay, let's see how much we can do, which is more important, for you, today. We can always, if we're not able to do, address all your concerns today, we can always book another appointment for us to, complete this consultation. So how you approach that kind of consultation where a patient has multiple problems, if you don't do it well, then it could be a problem. The implications of relevant findings identified during the data gathering were insufficiently recognized or understood. In other words, how do you pick up cues and clues from your patient? If you're not able to pick up clues or cues, then that's of course, is a problem. Differential diagnosis or hypotheses were inadequately generated or tested. For instance, a patient who has had cough for 2, 3, 4 weeks. You haven't asked about coughing up blood or any blood stains in the sputum. You haven't ruled out, checked for weight loss. Is the patient a smoker? Any family history of lung cancer or things like that? So differential diagnosis. Okay, every cough is not just asthma, for instance, or chest infection. Decision making or diagnosis was illogical, incorrect, or incomplete. Remember, the first domain is data gathering and diagnosis. So decision making or diagnosis was illogical, incorrect, or incomplete. So if you make the wrong diagnosis, or if you don't even make a diagnosis, if you forget to mention your diagnosis, I suspect that you might have a chest infection. And the reason for that, the reason why I think that is you've had this cough for 2 weeks, you're coughing up greenish phlegm, you've had some slight temperature, things like that, you know what I mean? Domain 2, clinical management. Standard for marking, domain 2, passing level. The candidate demonstrates the ability to formulate safe and appropriate management options, which includes effective prioritization, time, self-management, and continuity. The candidate demonstrates commitment to providing optimum care in the short and long term, whilst acknowledging the challenges. So the first one, you have to be able to formulate a safe and appropriate management, effective prioritization of symptoms, management of your time, self-management, and ensuring continuity. Continuity means, for instance, arranging a follow-up where needed, encouraging a patient to come back, to have a follow-up or a visit with you after they've been discharged from hospital, for instance. Giving sensible, reasonable safety net advice where needed. Feedback statements for domain 2. The management plan relating to referral was inappropriate or not reflective of current practice. So you could be saying things that were right 5 years ago or 10 years ago. So if your management plan is not in tandem or in keeping with current practice, or is inappropriate, then obviously you could score poorly in management. The management plan relating to prescribing of medication was inappropriate or not reflective of current practice. And this is so common to make this error with antibiotic prescribing, especially when it comes to pharyngitis, sore throat and cough. Is it a viral respiratory tract infection or a bacterial respiratory tract infection? So the question is, do you prescribe antibiotic? Or do you do a delayed script? For instance, I think I really suspect this is a viral infection, which hopefully should get better in the next couple of days. However, because you've had this cough for over a week now, or for up to a week, and you felt a little bit unwell with it, I'll give you this antibiotic, which I think you should hold on to, and I'll advise you only start it if you become very unwell or you develop a temperature. A delayed initiation of antibiotic, for instance, versus not even giving that option. So you have to be able to tease out between a viral infection and a bacterial infection in terms of antibiotic prescribing. The examiner thinks you were too liberal and inappropriately prescribed, a course of antibiotic for a very likely viral infection, then that becomes a problem. The management plan relating to investigations was inappropriate or not reflective of current practice. The management plan relating to prevention, health promotion, or rehabilitation was inappropriate or inadequate. If you need to be talking about smoking cessation, advising a patient to manage their weight, cut down on their alcohol, and things like that, and you haven't really considered those things in your management, then that could be a shortfall for you. The plan relating to the medical management of risk was inadequate or inappropriate. The implications of comorbidity were insufficiently considered. The implications of comorbidity. Uncertainty, including that experienced by the patient, was managed ineffectively. Inappropriate or inadequate arrangements for follow-up, continuity, and/or safety netting. So it's very important to ask yourself towards the end of your consultation, should I be seeing this patient again? And if yes, how soon? If no, do I need a safety net advice for this patient to identify certain symptoms that could happen, and then get back to me? And if they're not able to get back to me, who can they get back to? So for instance, if it's out of hours, you can ring 111. If you develop a collapse or a severe chest pain, crushing chest pain, you need to be ringing 999, the ambulance. So things like that, weighing up the options for your safety nets. Time management in a consultation was ineffective. Essentially, if you run out of time, if you're not able to do everything because you ran out of time, or you were just rushing through the consultation because you were running out of time, so time management was ineffective, is also a shortfall in domain 2, which is essentially management. Let's move on to domain 3. Domain 3 is relating to others. Feedback statements. Domain 3, passing level. The candidate demonstrates ethical awareness. So applying the principles of medical ethics falls under relating to others. The candidate shows ability to communicate in a person-centered way. The candidate demonstrates initiative and flexibility in using various consultation approaches in order to overcome any consultation barriers and to reach a shared understanding with the patient. So your communication style should be smooth, empathetic. You should give adequate room to listen. So you shouldn't be the only one talking. You should give time to hear, chunk and check patient's understanding, find out their ideas, their concerns, their expectations, find out if they're happy with the recommended plan you are discussing with them. And ethical awareness. Okay, for instance, a patient or a relative coming to ask about, get information about the medical history of a relative, and you haven't got a clear consent for you to give out that information. How do you manage that kind of situation? Feedback statements for domain 3. So what are the things that a candidate could do that would be classified as a shortfall in the relating to others domain? Communication skills, including the non-verbal, responding to cues, and/or active listening, were insufficiently demonstrated. The person's agenda, health beliefs, and/or preferences were insufficiently explored. Essentially not exploring the ideas, concerns, expectations, psychological and social impacts. The circumstances, relevant cultural differences, and/or preferences of those involved were insufficiently responded to, which is essentially expectation. The person's agenda, health beliefs, and/or preferences were insufficiently explored. The circumstances, relevant cultural differences, and/or preferences of those involved were insufficiently responded to. So if you don't respond to the patient's or relative or the carer's expectations, even if you think you're not going to meet those expectations, you need to acknowledge the expectations and explain why that might not be the best thing to do at that point in time. Because if you don't address their expectation, the likelihood is that they will book another appointment with someone else as soon as they drop the phone, as soon as they leave your office. Explanations were inadequately shared or adopted for the patient's needs. How do you share your explanation or management? By checking understanding first of all, and also by laying out the options There are different things we could do. We could do this, we could do this. What will you want? What are your thoughts on this? On everything I've mentioned. What do you think you would want to try? A judgmental approach was shown to the person. So if you're judgmental, demeaning, belittling, that's a huge problem. Respect and or sensitivity shown to the person was inadequate or inappropriate. Ownership or responsibility for decision making was inadequate or inappropriate. So you need to be able to own your decision. You don't shy away from being responsible for the things you're telling your patients. Okay? Teamwork and or understanding of others' roles was insufficiently recognized or responded to. Safeguarding concerns were inadequately recognized or responded to. For instance, a child who is looking malnourished, or a child who has a bruise, unexplained bruise, or a person with learning disability, who is in a residential home and is having abdominal pain. Is there a possibility of trauma? Physical abuse, there's possibility of sexual abuse. Can someone, a 30-year-old patient with severe learning disability, be pregnant with an ectopic pregnancy? That becomes a potential safeguarding concern. You need to ask those kind of questions, but in a respectful way and in a non-judgmental way. For instance, you could say things like, these are things, whenever we see, people with, vulnerable people, we want to ask certain questions to make sure they are kept safe. They're always safe. So, and then you ask your questions. Is there any chance that there might have been any forms of abuse on Jerry or on Anne, things like that? And you say it in a very sensitive way, and then listen to what the carer or whoever is looking after them has to say. So using the feedback. Following the results, the trainee is encouraged to discuss the feedback with their trainer and or educational supervisor. Of course, a lot of people, most people who will pass will probably not even bother discussing that. It's usually more helpful if you are not successful in the examination, so you can know exactly what you need to do and what you need to get right before you apply for the next sitting. The feedback may raise similar themes to those who have been previously identified, or it may suggest some new areas to work on for the future. Experience shows that it is often most useful if a particular feedback statement is repeatedly marked, or if the feedback is found repeatedly in a particular domain. The odd single feedback statements relating to one case may be less useful. Should the trainee need to make future attempts at the SCA, it is encouraged to avoid focusing solely on the areas where they received negative feedback. For example, if the trainee received feedback about inadequate safety netting, overemphasizing safety netting may be to the detriment of these consultations where it is not needed. It may appear formulaic or take up too much of your time. So these are the things, information that the Rcgp has laid bare to us who will be sitting the SCA. And the duty is on us to make sure we don't do these things that could, make us score poorly in the several domains, marking domains. Above all, I wish everyone success. Cheers.